Our next topic of discussion is going to be depression of ventilation, or as I like to say, O2 induced hypoventilation. I like to break it down that way. Instead of saying depression of ventilation, I say O2 induced hypoventilation. And the reason I like to say it that way is because I can break the word down, this statement down, and have an idea of what is the problem, what's causing the problem. First off, we have oxygen, and it is inducing or causing hypo, which means low, decreased ventilation. So we have this condition in which when we administer oxygen to a patient, it's causing the patient to ventilate less than what they should. Well, you and I, everybody has this hypoxic drive, which responds to levels of carbon dioxide, and we also have these peripheral chemoreceptors, which respond to levels of oxygen in our blood. Well, when they're responding appropriately, when we have low O2 in our blood, our body says, breathe more, and we try to get more oxygen into our lungs. When we have high levels of CO2 in our lungs and in our blood, what we end up doing is we breathe more so we can blow off that CO2. Well, when this happens and we are giving patients supplemental oxygen, there's a special class of patients known as your COPD CO2 retainers. And these are patients who have extensive lung damage. And these patients, they have elevated levels of carbon dioxide at all times. And because they have these high levels of carbon dioxide in their system, the hypoxic drive, which normally responds to high levels of carbon dioxide to regulate ventilation, is suppressed. It's blunted. It's not working. So that the COPD CO2 retainer has to rely solely on the peripheral chemoreceptors to regulate their ventilation. So, if we supplementally give a COPD, CO2 retainer, oxygen, and we give them too much oxygen, well, that oxygen will cross the AC membrane, get into the blood, and if there's too much oxygen in the blood, the peripheral chemoreceptors will pick that up, and that will tell the brain is, I don't need to breathe as much, and you will see a decrease in the ventilation. So, whenever you see a patient who is a COPD CO2 retainer, a known COPD CO2 retainer, you need to be aware of the level of oxygen that you're delivering to that patient. Normally, keeping a PaO2 between 55 and 60 is acceptable for a COPD CO2 retainer. And the way you can tell that your patient is a COPD CO2 retainer is to look at the blood gas. You're going to have a pH on the lower side of normal between 7.35 and 7.39. You're going to have a higher than normal level of carbon dioxide, 50, 60, 70, 80, 90. And the telltale is also going to be that the bicarb is going to be elevated above normal. Normal being between 22 to 26 milliequivalents per liter. When you see that, you need to make sure that you're not giving too much oxygen to your patient. And what I would look for is to keep the PaO2 level around 60. Remember the oxyhemoglobin dissociation curve? When you have a PaO2 of 60, you're going to have a saturation about 90. Remember again, even if your patient is a COPD CO2 retainer and it's a critical situation, you never withhold oxygen from the patient, because that is what's going to help that patient the most. It's going to protect the heart, it's going to protect the muscles, it's going to protect the brain. Once those organs get deoxygenated, they can die. Well, we don't want that. So give them the oxygen, because we can always ventilate a patient. We can always help them ventilate. But if the brain or the heart becomes anoxic, or the O2 levels in that area are so low that the tissue dies, there's no coming back from that. So again, O2-induced hypoventilation occurs in your COPD, CO2 retainers. And this is a special class patients again. And these patients will normally have a pH in their arterial blood gas that is decreased, which is probably going to be between 7.35 and 7.39. Your PaCO2 is going to be increased, which means it's going to be higher than 45 millimeters of mercury. And I don't really care how high the CO2 gets, as long as my pH is in the normal range. And you're going to see a bicarb that's going to be greater than normal. Normal being 22 to 26. So I'm going to tell you that it's going to be like increased above 26 millimeters of milliequivalents per liter. Now your PaO2 levels, we don't want those patients having a PaO2 that's too low, because it's going to put the heart and the brain at risk for damage. And again, this one is depression of ventilation, also known as oxygen-induced hypoventilation. Thank you.